Good morning, this is Dr. Rutledge, and we're doing a series on the technical details of the mini-gastric bypass. Let me remind you that there are other informative videos available in my series on YouTube. Right now we've had over 2.5 million views, and recently in Spain we were pleased to have over a dozen leading experts in the performance of mini-gastric bypass meet at the International Federation for Surgery of Obesity European chapter meeting in Barcelona, talk about their experience in doing the mini-gastric bypass. And we actually were a little bit surprised to find that there were a few surgeons who actually, quote, learned how to do the mini-gastric bypass on YouTube. And I think this is both flattering and concerning. So what we want to do is provide some other background, some tips and pointers and things like that to encourage surgeons to contact me directly, and others who are experts in the area who are happy to provide tips and pointers and help, and even proctoring and visits. I've had the good fortune to visit surgeons doing the mini-gastric bypass in Paris, in Rome, in Germany, in Freiburg, and in Cologne, and in Spain. And also I've had the good fortune to be invited as a visiting professor to India, to Turkey, and so it's something that's available, and these tapes are not intended to be instructional, but more supplemental for those surgeons who are changing over. As we say in all these tapes, it's the opinion of myself and the other surgeons that met in Barcelona that really the mini-gastric bypass has kind of numerous advantages that in our minds make it close to an ideal weight loss surgery. It's short, it's simple, it's very effective, it's easy to revise or reverse, low incidence of bowel obstruction, low incidence of complications, it's durable over the long term. And when we look at the other types of operations, it's our opinion that they fall short in one or several of these areas in comparison. On the other hand, there is a long-term risk that is equal to the risk that the other kind of bypass called the Roux-en-Y bypass gets. And in fact, it's true of all of the connections done between the stomach and the intestine that have been done by surgeons since Bill Roth first did it in the late 1800s. And that risk is marginal ulcer. So our feeling very strongly is that this is a long-term danger, and we feel it's a very reasonable trade-off given the very positive effects that the weight loss surgery has on our patients. But it's important to remind our patients and our surgeons when they're offering it that there is a very significant long-term risk, as well as a low incidence of short-term and other long-term risks. But marginal ulcer, ulcerations, bleeding ulcers, or perforated ulcers are really the big issue, and there's some things that can be done to prevent that. So we always emphasize this, and I'm delaying the main topic of this tape just to remind both the surgeons and the patients who might consider it, is that ulcers can happen. What we find in my series is about a 5% incidence, which is not too much different than if you were to take an aspirin every day. Studies from England, where they have a social medicine and they have data so they can follow everyone who took aspirin in a year, noted in a very large series about 6% of aspirin takers have bleeding ulcers, irritation, or gastritis every year when taking aspirin. And the mini-gastric bypass, the Roux-en-Y gastric bypass, and in fact all kinds of connections between the stomach and the bowel, that's called a gastrojejunostomy, get this same kind of problem complication. So we want to warn you, and there's some things to prevent it. Don't smoke. In many of the studies looking at why people get ulcers and perforated ulcers, smoking comes out number one in a very large number of these, so don't smoke. If you do smoke, don't get a mini-gastric bypass. Don't take aspirin in combination. And so there are just some things you don't want to do. In the event that you get some symptoms, which is burning, dyspepsia we call it, upset stomach, spitting up, gut, bowel, belly contents, burning pain, these kind of things, they should be a red flag to get medical care really quickly, because it could be a sign of something very serious. So, especially if you're taking aspirin, sometimes maybe in smokers. And we feel that in the incidents where you get a little bit of irritation at the stomach, it can be made worse by pouring kind of caustic, sharp type things on top of that, just as if you were to pour that same kind of liquid on an open wound, which is, in my way of thinking, a lot like an ulcer. So we recommend our patients also avoid alcohol, in addition to a very strong argument against smoking. We say alcohol, coffee, and even soda pop, which is a mixture of phosphoric acid and sugar and some flavoring. We don't really like that in our MGB stomachs. And again, some people say, well, gee, I can't live that way. And then we say, it's really not a good idea to have the mini-gastric bypass. Another big topic is NSAIDs, and that's an abbreviation. NSAIDs is NSAIDs. It is an abbreviation of the non-steroidal anti-inflammatory drugs. And these are well known to people. They are the aspirin, Motrin, Aleve, and all of the other brand names, ibuprofen, and other drugs. They also include Tylenol, which we'll talk about later. But all of these drugs, excluding Tylenol, burn, irritate the stomach, and can cause ulcers on their own. So as we're talking about, if you don't have a mini-gastric bypass or a Roux-en-Y gastric bypass, and you take aspirin, you have a moderately high incidence of getting an ulcer, depending on how you classify moderately high. So that combination with the connection between the bowel, the Roux-en-Y or the Bill-Roth-2 gastric bypass type connections, we find it's kind of like striking a match to a dry tinder, that you're likely to get a burning ulcer. So we are very strong in our preoperative education, our discussion with our patients post-op. You definitely need to avoid NSAIDs, because the combination of a bypass, a gastrojejunostomy is a technical term, and NSAIDs is, in my experience, in the medical literature, in the Roux-en-Y gastric bypass experience, highly associated with bleeding or perforated ulcers, and you do not want a bleeding or perforated ulcer. So that brings up the question, what to do in the case of mild pain? And one potential answer is Tylenol, but if you watch late-night TV in the United States, you're starting to see ads from attorneys saying, have you taken Tylenol and had liver disease? And about 2 years ago now, an expert panel convened by the Food and Drug Administration of the United States said they felt, and they recommended to the FDA, that all prescription Tylenol-containing drugs be taken off the market. And the reason was that there is a moderate number of people who are taking these drugs, taking more than the recommended dose, ending up with liver failure and even death or transplantation. So we know that Tylenol potentially has a mild pain reliever effect, but if taken in too high doses for too long can be deadly. Now, it's not, those recommendations didn't go forward, and I have my own opinion as to why that was. There are fairly large corporations that make quite a bit of money selling acetaminophen and Tylenol. So my bias is that it could be that those expert recommendations weren't followed, potentially because of the effect it might have on the economy. But what I would say is we've learned from this is that Tylenol by itself isn't kind of the totally safe alternative to the other NSAIDs. The other thing we want to point out is the majority of the mini-gastric bypass patients who are obese also have fatty liver. And that means it's a damaged liver from the obesity, and we know that there is a lifetime stress on the liver from the weight loss surgery and the bypass. So if we get liver function tests late after gastric bypass, there's a mild persistent elevation, persistent evidence of irritation of the liver. And so we strongly feel that routine use of Tylenol is not a very good idea either. So if we take off all of the over-the-counter pain medicines, what is my recommendations for patients who have mild pain after mini-gastric bypass? My recommendation is for mild pain that there is not a good, safe, over-the-counter medicine for mild pain, and so I don't have any suggestions for those patients. I think it's one of the downsides, the trade-offs for having lost 150 pounds and potentially resolving diabetes. There's always, in my experience, a trade-off in life. You get something, you end up giving something back. In the case of the mini-gastric bypass, I would love to spend the whole tape talking about the benefits. And I think there are some really significant benefits, but a real important issue, besides the bleeding ulcer, is I feel that there are some risks for taking any of the over-the-counter pain medicines, and so I generally recommend to my patients you avoid that very strenuously. Now, having said that, if you take one ibuprofen tablet, will you keel over dead? No, I don't think so. If you take one Tylenol tablet, will you have a sudden death? Will your liver suddenly go away? I don't think so. So, I'm hesitant to say this, but if you take one or two tablets once a year of something for mild pain, I think that's all right. In general, though, I think it's safest for mini-gastric bypass, for morbidly obese patients who've had bypass and other rapid weight loss type surgeries, that avoiding Tylenol is wise. I think there's some well-known dangers. I certainly wouldn't take too much. I certainly wouldn't take it for too long, even though it's available over the counter. I would not take aspirin and other type NSAIDs with the MGB. And so then the other question occurs, what if you have mild to severe pain? And my answer there is I think that that is best treated by narcotic type pain medicines. And that's the codeine, morphine, Demerol, and medications like that that require prescription. So to simplify this, I'll kind of repeat it, which is mild pain, I don't have a suggestion other than during the time when you're suffering that mild pain, recall all the benefits of the weight loss surgery that you've had, although it's maybe small comfort if you have something annoying. But if it's more severe pain, then we recommend a stronger pain medicine, and basically that's something from the narcotic family like codeine or one of the other narcotic pain medicines. Mild pain, we don't have any really good choices. I whisper under my breath maybe one or two Tylenols once or twice, but I'm opposed to that in general as a routine treatment. In general, mild pain, I think, is something that is mild, and so I recommend not treating it with potentially deadly and dangerous drugs. The other thing to point out is that these medicines are mild pain relievers. They're not classified as major pain relievers, and for a reason they're mildly effective. So, in summary, I would want to recommend you are careful about the risk of ulcers. Avoid smoking, alcohol, and irritants in the stomach when you have some gastritis or an ulcer. You're very religious about avoiding taking any NSAIDs. And then there's something good you can do. That is, the good research suggests that some of the ulcers that we have, in fact many, depending on the person, the country, and other factors, may be caused by a bacteria. And that bacteria has the somewhat long name Helicobacter pylori. And so in those cases, patients who have irritation or upset stomach can often be treated with an antibiotic that kills that bacteria along with antacids. There are some research in my clinical experience with my MGB patients, replacing the gut bacteria with healthy bacteria that's in our gut I have found very helpful. And what I mean to say by that is you and I are filled with bacteria. And that bacteria is, in many cases, good for us. There are some bad bacteria, obviously. For example, the Helicobacter pylori, which we're not crazy about because it is a potentially disease-causing bacteria. But lactobacillus, the bacteria that's in yogurt, and also, for example, in sauerkraut, is a very, very helpful bacteria. And in several studies, the intake of yogurt or lactobacillus has been shown to help eradicate and help prevent recurrence of Helicobacter pylori. And infections of Helicobacter pylori are associated with ulcer, as we talked about, and potentially it may be a long-term cause of gastric cancer. So, in my experience with my patients, I strongly recommend and have seen really good results if our patients will take some regular plain yogurt every day. And I mean every day for the rest of your life. It doesn't have to be a full cup, but some yogurt replacing and repopulating the gut with that good bacteria, I believe is a critical and valuable technique for our patients. So I strongly recommend it. And I've seen over and over again where patients call me 1, 2, 3, 5, 10, or even 15 years after the surgery, and they've had a flare-up of this burning pain. Maybe they'll even be spitting up or throwing up bile. And we'll go through and talk with them. And we'll find out they're taking a medicine, like the NSAIDs that upsets, irritates, or damages the lining of the stomach. They may be drinking alcohol, they may be smoking cigarettes, they may be eating just a poor diet, and again, fresh fruits and vegetables seem to be help in protecting, and a junky processed food diet is not so good. There are a few studies suggesting that plain milk is not helpful, and that it's really the fermented type yogurt that is helpful as far as protection in ulcer disease. I don't know how strongly I feel about that, but I would say if you're in the situation where you're having burning pain and difficulties like that, I personally would be very aggressive about following these guidelines until you feel better. Also, obviously, you need to see your doctor or come back and visit me at the clinic right away if you're a patient of mine. Even if you're not, come see me. So yogurt, we think, although it sounds kind of homebrew, kind of like old wives' tale kind of idea, is really a critical factor. And for a lot of other reasons, we think that the connection between the stomach and the bowel, the bypass, can kind of mess up the gut bacteria. And so it's a really valuable tool to just normalize that gut bacteria every day with a spoonful or two of yogurt, even as many as 2 or 3 times a day. And it doesn't, again, have to be a ton of it, but it also, of course, contains protein and calcium, and there's good research now on the fact that taking calcium tablets may not be as advantageous as actually dairy, so you kind of have a triple crown. That sour, unpleasant-tasting yogurt is something that gives our patients a lot of benefits. And potentially, in the case of a bleeding or perforated ulcer, I mean, it could be life-saving, because that's a concern. Other things like cramps and gas and other kinds of gut problems, which have been shown to be related to overgrowth and, quote, bad bacteria, unquote, we think that there's a real advantage long-term for yogurt. So I'm a big proponent of yogurt. I have several videos on my concerns about the yogurt that's been transformed by American companies into all kinds of things like, my favorite is frozen yogurt, which that's not what we're talking about. So, I mean, I'm sure that's tasty, but I view that as candy and an occasional treat or something like that. But we're saying for health reasons, the research I can read, it's plain yogurt that works best. I don't know if I would choose non-fat yogurt myself. I kind of prefer either regular, plain yogurt. It's possible maybe a lower fat yogurt might be acceptable. And there are several other videotapes on this. So that's what we're talking about this morning. I want to get started on that, give you some pointers and background on that. We're going to have more technical details in some of our other videos, but hopefully this is useful to you. There's some other videos on more detail, and of course, don't hesitate to email me. You can also call and leave a message. I'll try to call you back. But this gives you some background and details on the mini-gastric bypass, and stay tuned for more tips and pointers for the surgeons who are interested on the actual performance and the technical details of the mini-gastric bypass. Thanks very much.